So, good morning, good afternoon, good evening for wherever you are dialing in from around the world. My name is Peter Cressy. I am the marketing manager at Sigvaris Group Britain. A very warm welcome to this MOH, the Medical Online Hub, brought to you by Sigvaris. So, we have a fantastic session for you today with the Lymphoedema Wales Clinical Network team. Your host is Dr. Gary Cooper. So, without any further ado, I'll hand over to him now. Thank you.
Thank you for that, and a good afternoon to everybody that's joining us today. My name's Dr. Gary Cooper, and I'll be hosting today's webinar, which is focusing on cellulitis and lymphedema, lessons from the Lymphoedema Wales Clinical Network, our journey, progress, and future directions. What I'm always pleased is to see a wide range of people joining us today. The breadth of people on the webinar reflects something important. Cellulitis and lymphedema is not a niche issue, it's a system issue. And many of you will know that cellulitis remains one of the most common, serious and costly complications of lymphedema. It drives hospital admissions, antibiotic use, and recurrent episodes create service pressures and, most importantly, significant patient distress and disruption to their everyday lives. So today's session offers something slightly different from a traditional guideline-focused talk. Instead, we're sharing a national journey, that of Wales. Through the work of the Lymphoedema Wales Clinical Network, Wales has moved from a relatively fragmented approach to cellulitis management towards a more unified, data-informed and prevention-focused national strategy. However, anything of this scale is never a straight line. It's involved challenging variation in practice, building a multidisciplinary partnership, strengthening antimicrobial stewardship, and embedding audit and evaluation. And importantly to all of us is also listening to the voices of those living with lymphedema and the complication of cellulitis. So today is an opportunity not to only hear what has been achieved, but to reflect on what has been learned, including what didn't work, what required adaptation, and where there's still work to be done. So I'm delighted to introduce our speakers from the Lymphoedema Wales Clinical Network. We have Linda Jenkins, who is one of the national lymphedema and cellulitis leads in Wales, and Dave Graham Wallard as well, a national lymphedema and cellulitis lead in Wales. So they will begin by setting the scene, outlining the burden of cellulitis and lymphedema within the Welsh context, before taking us through the developmental journey of the strategy and the measurable impact of that achieved so far. Following that, we'll move into a more reflective discussion, exploring key learning points, challenges, and future direction. There will, of course, be time for questions towards the end, so please use the Q&A function at the bottom of this Zoom so that you can post your questions throughout as they arise. So, without further ado, I'll hand you over to Linda and Dave to begin telling us about their journey.
Welcome, everybody. I think it's me leading off today. I'm just going to share my screen. I'm obviously Dave Graham Willard. Let me just share the screen. There we go. I'm hoping that everybody's got sight of that.
Yes.
Yes.
Fabulous. Always good to get a confirmation, to be fair. So, as Gary has said, we are the National Cellulitis Improvement Programme team. We're part of Lymphoedema Wales. So, myself and Linda share a role as National Cellulitis leads in Wales. And just to give a little bit of background of where we are. So Wales, part of the UK, a small principality. We're a relatively small country, and the population's around 3.2 million. And healthcare within Wales is part of the NHS, and we're split into 7 health boards. They're geographically spread around the country, and we're a pretty rural country. But most of our population tends to be down something called the M4 corridor, which is at the southern end of the country. Each health board, though, within Wales does have its own lymphedema, local lymphedema service. And we, as NCIP, National Cellulitis Improvement Programme, sit within the national team. So we sit within the National Lymphoedema Wales Clinical Network, which includes those health boards, plus us as a specialist team, together with other specialist teams, including children, heart failure, and garment provision. So, what do we do? So, leading on for that's where we sit. Just a little introduction, just to make sure we're on the same page about what is cellulitis. So, we know It's an acute bacterial infection of the dermis and subcutaneous tissue. We also know it can be serious. It can be life-threatening if it's untreated. It can lead to sepsis and multi-organ failure. One of the most important factors we like to push ahead with the education work we do, it tends to occur only in one part of the body at the same time. So it doesn't tend to be bilateral. That tends to be other conditions. We know it's not contagious, which is great. And the majority of cases are caused by streptococcus, naturally occurring bacteria on the skin, which becomes opportunistic and then causes the infection. It is the most common skin infection that requires antimicrobials. And most of these occur in the lower limb, 70 to 80%, which links in really closely with its link to lymphedema. We also know there's a proven link between deprivation and cellulitis, and we will mention that a little later on. But so what? It's just a skin infection, it's just cellulitis. But as Gary intimated at the beginning, there's a huge impact in Wales and across the world. Hospital days occupied by a cellulitis diagnosis has a massive impact on that secondary care service. Over 7,000 admissions, and most of those were through emergency services. Over 3% of our emergency department contacts are because of cellulitis. It's a big number. Patients tend to stay in for a long period of time, up to 6 to 7 days. And even our general practitioners, so that's our local doctors, they are seeing around 200,000, probably more events for cellulitis. We know there's a high recurrence rate. The recurrence rate is massively increased for those with lymphedema, up to 71%, the patients with lymphedema. And despite that, we have a 39 to 41% misdiagnosis rate. And that's both for patients with cellulitis where it's been missed, and patients who have been misdiagnosed with cellulitis when they don't have it, leading to that inappropriate antibiotics use. And that could explain the massive increase in cellulitis prescribing in the last 10 years. So we've got a duty of care for antimicrobial stewardship. High use of antibiotics can lead to those C. diff rates rising and causing problems. And we want to get away from it is a big thing. It's the third most common reason for prescribing antibiotics, the other two being the UTI and respiratory infections. So it's a big impact on health services.
Oh, I think I'll jump in here, Dave, should I? And I'll do this journey bit for us here. Is that right? I think that was what we said. So this is just sort of talking through how it's come about in Wales, where we've come from. So there was obviously a pre-planning bit before Dave and I were in post, and we started in 2020. There was this pre-planning bit when the people working in lymphedema services, particularly people in the network who were overarching all of those health boards Dave mentioned, recognise the fact that a lot of our lymphedema patients get cellulitis. They also knew that once they were under those local services, once someone was helping them to manage their lymphedema, those cellulitis infections became less frequent. What they also hypothesized was that there was probably an awful lot of people in hospital beds having treatment for cellulitis who'd never come anywhere near any lymphedema departments, and so were missing out on that help. The evidence would suggest that about 50% of all people who have cellulitis will have lymphedema. And so with all that data, people more important than me and Dave went to Welsh Government with a business case and suggested what opportunistic cost savings there could be if we could intervene with these people who were getting cellulitis who weren't being managed very well. So if we click on the next bit, Dave. So what was established were 3 cellulitis leads. That's 2/3 me and Dave are. We have another colleagues too, and the 3 of us were established in 2020 to start looking at all the people in Wales who were being admitted to secondary care or admitted to hospital with cellulitis. Obviously, at that point in 2020, as you'll all know, we also had the COVID crisis. And that we'll talk about perhaps a bit later about how that was probably a barrier, but also an enabler to our service too. But we worked around it at that time. And we started off by just getting data from one hospital in Wales. That was what we did. We went to one average kind of sized hospital, not a massive one, not a small one, an average sized hospital, and said, can you send us the data for everyone who's been coded? We use the ICD codes. Everyone who's had a code for cellulitis or the allied kind of conditions in the last 2 years. We thought, let's just see what the numbers are. And that gave us just over 1,000 people, I think, that first time we got that haul. And our plan was that we would do that for every main hospital in Wales. And we worked our way, it took us probably the best part of 2 years to work our way around all the main hospitals in Wales, asking for all that data. And by the time we'd done that, we went back to the beginning and started again and said, okay, give us the previous data that we've now missed. And that's where we started. And at that point, we quite quickly recognised that there was a big education need here, and we realised that we needed to get in there and providing some face-to-face education. So as we move then on to the next one, what we started getting then was, rather than having to go back 2 years, because you can imagine contacting someone about an infection they had 2 years ago can make people have to stretch their imagination a bit and remember what happened to them. So we started getting more frequent data then. So we went to every 6 months, and we just got it for each health board, not each hospital. So each health board might have 3 or 4 hospitals within it, and we got that as a group. And to the point that we now get it for the whole country every 2 months. So every 2 months we get a whole heap of data sent to us that is anybody in Wales who's been admitted to hospital and had treatment for cellulitis, and that gets sent to us on a 2-monthly basis. So that's where we stand now. We also get data from GPs. So these are the general practitioners, community doctors, but really people not in the hospitals. They don't unfortunately code in the same way as the hospitals. They don't use the ICD code, so we can't get it that way. We get it off their antibiotic usage. So we have to kind of be clever, and we ask them to tell us about people who they've frequently given flucloxacillin to. It's the antibiotic we use for our skin infections here, and we get the data from that to get a cohort of patients who are having frequent antibiotics from their GP, most likely for skin. And we again send them an invitation letter. And alongside that, then we started doing lots of education sessions, primarily to GPs and practice nurses, general practitioners in the community, but also to anybody who'd listen to us. We'd send out invitations and we'd talk to anybody. What we're doing now, as we're continuing to evolve, is tracking our response rate, really. Who responds? We send people an invitation letter, and people respond to that letter or they don't. And when you have those kind of health invitations, you'll probably know uptake is pretty standard. It's around 30% for those kind of things, and that's where we sit. So we're trying to tackle that response rate and trying to engage with more people, because we know that there's a link to sort of equity with people in more deprived areas, in that we see a better response from people who live in the least deprived areas, and we want to make sure that we're being equitable about that. So that's kind of where we're sitting currently. And so the phases of work that's developed is this first phase, like I said, where everybody who turns up at a hospital and gets admitted has that code attached to their name, and therefore will ultimately receive a letter from us several months later, even now. But that's phase 1, is tackling those people who've been admitted to hospital. Phase 2 then is doing this education. So offering education to people in the community and to people in the hospitals to try and make them more aware about what cellulitis is and what they can do, what messages they can be given to people, how they can access us. The third phase that came off the back of that really was the work with the GPs. So these getting the data about their antibiotic usage and helping those people who never end up in hospital but are having frequent antibiotics. And from a stewardship point of view, that's really poor. So targeting them and seeing if we can help with them. And what we came across when we ran those reports and looked for that antibiotic usage is we came across quite a lot of people who were taking long-term antibiotics, predominantly phenoxymethylpenicillin V, which is written down here. And that is classically given to people if they've had their spleen out, but it's also given to people when they have recurrent cellulitis. And often it's given when they're maybe an inpatient and then it's never reviewed. And so people can end up being on it for years and years and years. Some don't even know they're on it. Some know they're on it and think they have to take it for life. And from a stewardship point of view, that can be a problem. So we try to intervene with those people and see if we can help them to get them off that as well, if it's appropriate. So there's going to be a lot of data here now, and I'm going to work my way through it. So this is just a snapshot. We've got loads of data, and this is on the first 9,000 people really that completed the program. And so we're just going to talk you through it. So when we talk about these first 9,000 people who've now completed the program, it's just over 50-50 male, female, so 52% men, 48% women, which is fairly typical if you see other worldwide studies. As Dave said at the beginning, the vast majority of people will get cellulitis in their lower limbs. So 75% of all of our patients have had cellulitis in their lower limbs, but you can get it anywhere. So you still get those 4% in their head and neck. We use the frailty score. I think it's called the Oxford Frailty Score. It's a worldwide frailty score, and we score all of our patients for that. So we know that nearly half of our patients have got a frailty of 4 or more, which is when you're tipping into the vulnerable. Really, 4 is vulnerable. So 4, 5, 6, 7 take you into the very vulnerable group. So we know that about our patients. As Dave mentioned about the health boards, these are the names of the health boards here in abbreviations. That's not important, but we do split all of our data across the health boards so that we can look at localities and offer more specific input if needed to certain localities. So In this case here, very little difference. We look at BMI of all of our patients, and there isn't much difference across all of the health boards. A little bit, but nothing too drastic there. So that's our health boards. If we looked at age, for example, which is this next one, I think here. So age here, we know that in some of our health boards, we have a more aged population. We also do it for frailty and everything else. So we can just target our intervention and think about what input is needed because of the data that we've got. But for the vast majority of our patients, 70% of our patients are over the age of 61. Again, helping us just to think about how we're going to deliver the service. So again, when we think about these 9,000 people, we can look at the data that we have about them. And we've got the lots of, because we've been doing this since 2020, this is about 5 years of data that we've got. So when we meet them, we have the data for their previous 12 months. So before we've met them, we know how many episodes of cellulitis those 9,000 people have had. And in this case, those 9,000 people had over 9,000. So 9,675 episodes of cellulitis between them. So just over one each. How many hospital admissions they had, how long that they'd been in for that, and what normality they'd lost. So for that, it might be how long were you off work and things like that. And then we've got the column next to that, which is the anecdotal reporting, that when they're on our books, how many of them tell us if they've had another episode, and drastically reduced numbers that you can see there. Very few people being readmitted, and if they are for short length of stay. On average in their life, people have had about 2.2 episodes and been to their GP nearly 3 times in their life, and overall been in for nearly 4 days. That's the average of all of our people. We asked them, again, this is anecdotal, so we'll ask them to tell us, was there an obvious reason? Was it because you just had an operation, it was a post-op infection? Was it because you'd fallen over and grazed your knee? Things like that. Is it because you've got a chronic skin condition? Do you have eczema, psoriasis, those kind of things? So we get data on that. The vast majority, the biggest cause has always been unknown. People didn't know where it had come from. It's about 30% of all of our cases would say, I don't know why I got it, it came from nowhere, and large numbers with wounds. When we look at their risk factors, you can see these, and again, this is split into the health boards across the top, so don't worry too much about that. The last column is the mean, but we look at how many of our patients that we've seen have got swelling, how many have got edema, and on average, over half, which is what the worldwide studies would also say, over half of the people that we speak to say they've got swelling. Large numbers of them are obese, got skin problems, things like that. The blood pressure then, so we look at how many of them have got blood pressure problems or taking blood pressure medications. So again, around half of all of our patients are taking blood pressure medications. And it's just something that we think about then is what is it they're taking for that? Because if it's amlodipine, one of the most common drugs that we give for blood pressure in the UK, that also causes foot and ankle swelling. So sometimes that can be a contributing factor to why people are getting this infection, because they've got swelling because of their medication. And we might ask our GPs, our general practitioners, to review that. The whole point is to try and figure out what is making them vulnerable to getting these infections. If it's edema, are we managing it? If it's because they're obese, are we helping them to manage that? If they've got athlete's foot, simple fungal infections, and that's the portal of entry, can we treat those things? So these are the key things here, looking at what might be making them vulnerable to infections and targeting those things. Okay, so don't be scared by this one now, and I'll talk you through it. But this is a really important thing when you're setting up a service or you're trying to prove your worth and show the evidence, as Gary alluded to at the start, how we can show what impact we've had here. So we didn't do this, I might have A-level maths, but this is beyond me. There are people in the NHS in Wales who look at the financial implications of health, really the health economics. And so this is what we've done here. So if we look at, this is the first 5,000 people. We asked for help with the first 5,000 people. So we had 4,977 patients who between them had 5,300 episodes of cellulitis. Let me take a sip, excuse me. And so you can cost that. You can say that means you went to the GP X amount of times and that costs £36. That means you got admitted to A&E. There's a cost attached to that. And so that gives you a total cost there of about 15 million, I think it is there, Dave, isn't it, at the bottom?
Yeah, just over £50 million.
Just over 15 million. That was before we met with them. That's what it cost these people to have their treatment in that previous 12 months. Now, lots of the evidence will say, as Dave said, there's a high recurrence rate. They'll say between 10% and 50% will get a recurrence. So we were conservative and we said, okay, then, if 10% of our patients have a recurrence, that would be 498 people. Bear in mind, we had 4,977. So that would say if 498 people had a recurrence, this would be the cost. And I can't see right down the bottom there, Dave. What's the cost there right at the bottom?
It's just under 1.5 million.
So projected, we could say these people are going to cost us 1.5 million in the next year. Now, we know, because we saw these people, that in actual fact, only 171 episodes of cellulitis. How many of them were admitted, how many of them went to their GP, how many of them had IVs, all that kind of things. And so we can see the cost there is, again, Dave, I'm going to need help because I can't see the bottom of the slide.
Sorry about that. It's 144,000.
So even with that 144,000, that's brilliant, it's gone now. If we considered the 50% recurrence rate, so we were conservative, like I said, we talked about only if 10%. If 50% of them had a recurrence, that cost would have been 7.5 million. So a huge cost there. And even though obviously you've got to take into account we cost, Dave and I don't do this for free. We do have mortgages to pay. So we have a staffing cost of about 390,000 with the whole team. So even with that 390,000 added to the 144, we're nowhere near the cost. So there's a huge cost saving here in intervening to help patients to reduce their risks and reduce the likelihood of what we know is likely recurrence. And so this is really, really useful when you're setting up services to have evidence and to get other people. Don't expect to be able to do it yourself, but to use people that you meet to help you to show how you're making a difference. And so a really useful tool to have. And even more than that, then, in one of those health boards that we talked about, in the Cardiff Health Board, they were fascinated to look at what the difference was if people engaged with us or if they didn't. So last year, in a 3-month period, they looked at how many people we'd invited, and we'd invited 320 people from one particular health board over that 3-month period. And they looked at how many of them had engaged with us, so responded to our letter, and that was 73, and how many of them hadn't engaged, that was 247. And then they physically looked at what had happened to those people over the next 6 months. They went into their health records and they plotted what they'd cost the health board over that period. So the 73 people who engaged with us, some of them had been readmitted, but on average, when they did get admitted, they were in for 5 days. When you looked at the ones who didn't engage, far more of them were admitted. They were in for much longer, and they had a much bigger cost. So the difference between the two was £5,000 per patient. So we were able to then sort of hypothesize that if we get more people to engage with us, for every one we get engaging with us, we could be saving £5,000. Go on, you fine, Dave, move on, that's fine. When we look at that in more detail and think about those people who didn't respond and try to think why they didn't respond, we've done a lot of work on this, trying to look at the invitation letter that we send to them. So can we make that simpler? Can we make the language simpler? We've had behavioural science theory applied to it, so we make it easier for people to respond to. We've had the language, obviously, and the literacy of it changed to try and make that helpful. What we know about our populations, and these graphs here are for each health board who we've invited, and they're split into areas of deprivation. So in Wales, we split every area, every postcode in Wales is tagged with being in a certain level of deprivation from 1 to 5, and apparently this is opposite to the UK, so there's other people from other parts of the UK here, the numbers are the other way around. So in Wales, number 1 is the most deprived and number 5 is the least deprived, so bear that in mind when you're looking at this. But what won't surprise you in all the health boards is we send more invites to the more deprived areas, and the graphs on the right hand side here are showing who responds to them. And again, it's the flip of that, unfortunately, in that we get a better response rate from the people who live in the least deprived areas. And so we know that we need to try and target people who may be finding it harder to attend or read our letters, or maybe they don't live at the same address anymore. People in more deprived areas are more likely to move more frequently, more likely to change their phone numbers more frequently. And so this is us trying to think, how can we target people who maybe need us most and are finding it harder to engage with us. We have to think about the coding delays. I said that we get the data from the coders, and that isn't live. So when someone goes into hospital, a doctor will say what's wrong with them or what they think might be wrong with them, and then some weeks later, a clinical coder, an admin person, will go through those notes and press a button to say what those codes are. And across the different health boards in Wales, that takes different amounts of time. So we mightn't get to hear about them until 4-5 months after they've had their infection. In some health boards, it might be a month later, but in others, it might be 4 and 5, depending on that. So that can make a difference as to how likely people are to respond if it's not relevant to them anymore, because it seems like ages ago they had their problem. Again, I've alluded to those hard to reach communities, those people who mightn't have a fixed address, might struggle with language, those kind of things, and trying to make sure we're being favourable to them and making it easier. And the other thing currently, I'm sure this is worldwide, is that there's an awful lot of pressure to cut costs and to look at what services are providing what for their money. We're a hosted service, so we work all over Wales across all of those 7 health boards, but we sit in one of them. We get money from Welsh Government and from all the health boards to provide those services. And at the minute, when they're all looking at where they can get a little bit of money back, our posts are under pressure. And so having all this data, having all this evidence is a good ammunition for us to say, look, this is what we do. Is one person does this, and we can show you the evidence for how many people we've, maybe prevented going back into hospital and things like that. So that the data is invaluable, but it's a challenge.
So this is me popping back in, give Linda a chance to rest her voice and have a little drink. So I think she took about 2 breaths during that. So some of the other work we've been doing, along with the education and support, is back in 2020, we realised that across Wales there wasn't a standard treatment protocol for cellulitis, especially in those patients with lymphedema. And as a service, we started to drive through some work to standardise the guidelines. And our colleague, actually, Joe Brown, led this work with us and ended up with standardised guidelines across Wales, which we now have for people with lymphedema and cellulitis across Wales. So they're getting standard treatment, nice guidance, which links really well with the education work we do with all the healthcare professionals we see. But the biggest emphasis I think we put in from here is not just about the antibiotics. We've alluded to the antibiotic use, and I have to say, as a service, we do an awful lot of de-prescribing as well as prescribing. So we work really closely with patients to look at risk factors and get beyond just the antibiotic use on treatment. And so looking ahead into the future, at the moment we're working really hard to get Cellulitis, so that's our patient-recorded outcome measure tool, validated. We've been really lucky with our service. We're working with the national team. Lymprom is already out there and validated, and we managed to use that. And we found Cellulitis, I have to be honest, massively useful, especially in the early stages. It highlighted an awful lot of issues that we hadn't considered with cellulitis, especially around the psychological and anxiety perspectives. We work really hard on education and awareness. As you can see, that we have a poster campaign that's right across Wales. Our posters are all in English and Welsh. I couldn't fit the Welsh one on this, but I will do for future presentations. And we work really closely with general practitioners. We invest with them. We find out what they want to know, what they do know, what they don't know, and then we roll out the education package to GP practices, and we actively seek the input. So we chase after the practices, the practice managers, and get in there either face-to-face or on Teams to make sure we get into the practices and speak with the GPs, the practice nurses. In addition to that, we're also starting to work really closely with community teams in Wales, with organisations such as the Welsh Rugby Union and the Young Farmers. So we're going outside of the immediate medical area to try and spread the word and the knowledge. And hopefully all of that will improve education, improve engagement. But from a direct engagement perspective, as Linda mentioned, patients are having cellulitis in primary and secondary care, rather. So they're in the hospitals, but we're not seeing them at that time. So our newest project, which Linda is actually leading, we're looking embedding ourselves into emergency departments. So we see patients when they're in the emergency department and on the wards. So we're picking them up really early because we know our engagement with them at that point will be far higher and more relevant to the patient. And the non-responder D9 call, so we code all our contacts with patients. So a non-responder call, patients who haven't responded to letters. We now know, especially with the financial restraints, we don't want to be sending out more and more letters. So we're calling patients just to follow up to find out whether they'd missed the letter, whether they didn't understand, and just trying to really engage with them to get that level of contact with patients so that we can get them involved in the program and in the project. And that is the whistle-stop tour of the NSIP program. There are a few references there. And what I would say, if you're really quick with your phones, there is a QR code there which will take you to the Lymphoedema Wales Clinical Network webpage, which has a huge amount of information on not just the cellulitis program, but everything Lymphoedema Wales is currently engaged with lymphedema, heart failure, lipalgia, and garment programs.
You can leave that a little bit longer if you like, and then we can take you down. I just think it gives everybody a little bit more time. One, I'd like to thank you both for that journey in terms of telling us, because it's incredibly rich but also informative around what's happened here. And what really stood out to me was it's as much as a cultural and system shift as it is a clinical one. And so with that, it's that whole approach that's come into play. And I know we're going to talk about this more in the next section, which is coming to a more reflective discussion phase within this. I've just also got to remind people that are on today's webinar, please put your questions into the Q&A aspect of the Zoom side of things. It'd be lovely to hear some of your questions that I can then put to Linda and Dave. But moving us on, and Dave, if you don't mind just taking down your shared screen, that would be brilliant.
There we go.
There we go. Now, I'm thinking about everything that you've learned across the time period of your involvement in this project, and let alone from the beginning to where it is now. I know you've highlighted some of the barriers, some of the enablers, and about the importance of education. But what are the kind of things that you feel that you've learned that can help others in those areas?
Oh, should I go first? I'll take Dave and I'll tag team this. We do this all the time. I think the thing that I've learned probably most profoundly is don't be afraid to think big, but start small. Our clinical director is always, yeah, we'll do that. And I'm just thinking, how on earth are we going to do that? She sees the end bit, she sees the vision. She's like, yes, we'll do that. And she's like, don't worry about how we're going to get there. We'll figure that out. We can have a go at this. We can break it down and we can start and doing small bits of it. And I think the other thing for me is probably something I read the other day that rang true, which is don't be afraid of resistance. I saw somebody had written, it was something academic, written about how without resistance, you can't make a clay pot. And it was talking about how you've got a lump of clay and you've got to have the hand on that clay to shape the clay. And it's true of everything. When people resist challenge, what you might be suggesting, quite often it's because they might have something valid, and it might be that can help to change what you need to do, or it might be that you can reassure them and actually that they've misunderstood what you want to do. But I think sometimes we're a bit fearful of challenge and resistance, and I think sometimes it can be your greatest strength. You can use that as an opportunity then to move into a different direction. They're probably my big two.
Which is great to hear. And I love the way that people could picture about the resistance in the clay pot that comes.
I thought it was really well written. I read it and I thought that's a really good example of how to, you need a bit of resistance just to shape you. You can't just go off with your own free hand.
Exactly. And I like the fact that it's dream big, think big, but then break it down into smaller parts that you can definitely achieve along the way. Because other than that, the big picture is one thing, but how do I get to it? So that's lovely to hear. Dave, I know you're going to come in with something else with that regard.
Yeah, I mean, for me, it's looking at the crisis and taking the opportunity. We started this in 2020. We had massive ideas. I still remember us sitting in a room in February 2020, and the world was our oyster, and then COVID came and sat on us. And at the time, I remember thinking, oh my God, we can't do any of this. What it forced us to do was think laterally. And actually, COVID became one of the best things for us. It really pushed people into the IT side of it, into the remote communication, and actually became a huge enabler for us to push out the project, to engage with people, to get our education in place, to link with patients. So that was one of my things. And the other one, I got to be honest, data is king. Find your data, find people who can get you your data. And as Linda said, I'm the same. A-level in maths, it's all way beyond me. But there are people who can really look at your data and go, this is what it's telling you. Engage with them, find them, get them involved in your programs, because they'll really help you if you're doing the right thing. But I also have to say, if you're doing the wrong thing, they can show you where that problem is, and you can move to a more effective pathway, because we want to make sure our interventions are both financially and health effective. Yeah, getting the best value for the patient.
And what's nice from that one is taking what appears to be not an opportunity and turning it into an opportunity, especially with the pandemic that affected us here in the UK, but of course internationally, but how that was turned around. And actually it did bring about positive things, as you say, about the use of technology, how we can use it to gather data or drive through education in a very different way. So geographically we become much smaller. Like today's webinar really is the fact that we've got a wider reach because of it, let alone about data. And I love that. It is about you not necessarily being the expert, but you having the curiosity and the questions to then find the people that may have those skills to be able to draw the data down and give you something to work on. And as you say, data is king, because that's what a lot of commissioners, if people have commissioners where they are looking for, to say, well, what's the problem? What are you planning to do? How are you going to save us money to improve things further forward? And certainly, Linda and Dave, in your presentation, when you hear about the cost was like 50 million and how much post-intervention it can be, it's a significant saving. Plus also, we're very fortunate in Wales to also have our Clinical Wales portal that comes to play, which gives us wider access, which I know is probably the envy of a lot of people, of being able to draw information and data, suddenly having the patient in one type of interface for a change.
So yeah, I think that's something we didn't realise how lucky we were initially, to be honest, when we set this up. And we've been really fortunate across Wales because of the way it's set up. Although we cover 7 health boards, the 7 different strategies, overall, NHS Wales gave us access to all the data. So the Welsh Clinical Portal basically holds most of the data for patients across Wales. There is some data excluded in certain health boards or in GP practices. But what it enabled us to do was have that immediate access, that real-time access to data on the patients to really support them. And as I said, I don't think we realised how lucky we were until we realised other people didn't have it. So
you kind of only know what you know at that particular moment until you start talking to people and realising that things are slightly different.
yeah,
and I think actually this moves lovely towards, about looking ahead, because I know there's lots of things going on there. That was hinted about the emergency department, but of course I know that there are different things going on around here around educational needs analysis, how that feeds then into the different programs, the way they're delivered. So what would you say are the kind of key points for your future direction and sustainability to keep the momentum going on this moving train that is NSIP?
I'll come in here. I think probably the main thing is to never sit still. That would be something that I would have done. I thought, oh, this is really good. Look at this evidence. We can show you here that we're doing marvelous things. We'll keep doing it. But fortunately, people above us have ingrained in us that it's never good enough. There's always going to be something else. And so the big thing for me at the minute is the inequalities, is knowing who it is that we're missing, and knowing that those people that we are missing are probably the people who are more likely to use the emergency departments and to turn up in A&E, and probably not to use the more planned routes for their healthcare. And so the ED work is my baby at the minute. My big push at the minute is to be at the front door and on the wards. Lots of evidence that shows that when people have an acute infection, that they are more able to take on board advice, so that it's like a purple patch, a teachable moment they call it, when people are there. There's lots of evidence from smoking cessation and things like that about when is it perfect to time people to get them to engage with what is preventative. And this is a big swing for people. Remember that most of us are used to going to get help when we're unwell, not accepting help before we get unwell, and that's a big mindset switch for all of us in the UK. And so making people understand that we're trying to help them when they're not unwell, to stop them becoming unwell again, is a big change. And so that's kind of the big push for us, is tackling the inequalities by trying to get at the front door when people are having their infections, and they all present at A&E, regardless of where they live and what their postcode is and what age they are. They'll often come through A&E, so then we should be able to scoop them up as opposed to trying to get them on the phone. So that's probably the big push there. And then there is stuff, Dave, isn't there, about health needs analysis and stuff? Or have you got anything more to add there, Dave?
Well, yeah, just from where we're expanding out from that traditional package of medical professionals into the community, to say it's not just about that. It's given responsibility to people to say, yeah, this is out there. As I said, but we're linking in with sport, we're linking in with industry, trying to go from that direction as well. So because we can, we do a lot of work with education with medical professionals, and I have to say, after a bit of initial resistance, it's working really well. We get feedback from them about what we're doing, whether it's useful for them, whether we're teaching the right things, what else needs to be known, and that has definitely changed. We know anecdotally in Howell, especially in one of our health boards, the referring patterns and prescribing patterns have changed over the last 4 years because of what we're doing for the good. So now it's about, for me, it's keep pushing that education. Don't rest on our laurels. Do we need to change it? How Can we present it? Can we do it in different ways? Webinars, pushing things out on Facebook, on YouTube. It's brilliant. We've got pushing our social media within, and we are so lucky in the National Lymphedema team. We have such a great team. I mean, our leads have such good ideas and bring things in from both research. So whatever we think of, pretty much we can do to a degree. So pushing that through. But I think that's where we're at the moment from my side, is the education side and the expansion into the community as well, which will support the work, obviously, that Lynn's pushing as well.
Yeah, exactly. And as you say, it's kind of moving away from like the planned way that people might, or we think might, access services, say through the general practitioner, to where they might be going, whereby they might not have reached our lymphedema services, they might not believe they've got an issue, and suddenly they're presented there as that opportunity to reduce the complication, but also refer to the relevant services, let alone, which I do absolutely love as well, is going into those communities that are at risk, that we are starting to engage in that wider dissemination of information and prevention and self-management, because one speaks to one and then they will talk to lots of different people, and hopefully then they even see other people with a similar issue or the issue that we're talking about, lymphedema, and perhaps give them advice going forward. So it's great to hear that around it, and let alone technology. I know that we've kind of used MS Forms, these easily items that certain people may have access to, and maximizing their use to get data more easily, but also to engage with people in different ways, social media and everything else. So it's all great to hear that, because that's about the sustainability. How do we keep what we've done already going forward, but how do we keep on increasing our reach beyond our normal audiences, who are the ones that we haven't heard of that we really need to hear from? Excellent. So I'm just wondering here, others may be thinking, well, you know, we don't have a national team, we don't have this. So my question to you is, how could they translate all your learning, all of your aspects that you've learned, into their own context, their own practice? What would you give as advice to them about how to take things forward from their perspective?
I think I'd say you don't have, you know, we're part of a little nation, so yes, but really and truly, I think we said the other day, we're probably smaller than Manchester in a population. You know, with Wales, it's spread out over a lot of mountains and some lovely rivers, but ultimately our population isn't particularly big. We know about our population. As I think Dave said earlier, wherever you are, start to just build your network, start to get to know people who might know something that you don't. You might be a great clinician, you might be, whatever your role is, you might know that this is a problem, you might have recognized that problem, but you thinking, how on earth am I going to cope with that? How can I haven't got the skills for that? So find people who have, and you'll be surprised that someone in finance, someone in what we would call value-based healthcare, which is a platform we use in Wales, someone in a local GP surgery might just link with you and think, you know, I see that as well, and I can tell you I know that because I've got the data that backs that up. So think about what you're passionate about, what you know is a problem, and try and expand your network and see if you can build on that. And then you'll be surprised where you go. Start, like I say, start small then, you know, and think, well, let's just do a little investigation here, a little pilot, a little dig around and see what we've got data-wise. And then don't be afraid to put your head above the parapet and go somewhere and present it and make a poster and submit it and get things out there, so that suddenly your name is known a little bit, and somebody might approach you then and say, you've done that little bit there. I've been trying to do that here and I've been able to. It's just trying to network a bit, I think, is probably key.
Yeah. And I was just wondering about networking, because I know some people suddenly go, oh gosh, how could, one, they might not like networking in its own right, but two, they almost think about, well, where do I start? Well, what was the key places that you started with? I know it's from our kind of context, the Welsh context, but what would you say that might be the case?
I'd say, Dave, I'd say it's probably the fact that we come from different places, in a fact that, like Dave and I have talked about before. So the three of us, the three leads, myself, Dave and Joe, have different backgrounds. You know, Joe, our colleague who's not here today, is a paramedic. Dave and I actually trained together. We're both physiotherapists, but we both worked in different sides of the country in very different fields. And so we all had our own little networks, I suppose, and higher bits of knowledge and who we knew. And then pulling all those into a team, I don't know if you can add any more to that, Dave, than me.
I think the variation, it's having the ideas, you know, think big, start small, but don't be afraid to speak to everyone. I mean, I think Linda and I bore the rear ends off most people because we go wherever we are, we talk about it. And the number of times we've been chatting away and suddenly an accidental conversation turned into something bigger. And that's what I would say is, like, if you're passionate about it, if you want to do something about it, every time you get the opportunity, you talk to people. Yeah, some people won't be interested at all or have no engagement, but occasionally you'll get the one where, oh, my department has some information on that or something. That's how I would start if you're not sure. Just little subtle chats over the coffee at lunchtime, those sorts of things. We've got loads of benefit, as well as having, as Linda will say, our lead Mel is superb. I mean, she has brilliant contacts with the higher echelons in healthcare, in government, and they are really, really beneficial, and we couldn't do without them. But we can't all get to that bit sometimes. Just start small, have the chats. Sorry, Linda.
No, I was interrupting you. Sorry, I was just thinking we forget sometimes what is very common sense to us because we say it all the time. So little things that we say to our patients every day, or little things that we know about cellulitis because we work in it all the time, are actual golden nuggets for some people. Then when you meet them and you say, "Oh, did you know that between 10 and 50% of people will get a recurrence?" And a GP could be like, "God, I didn't realize it was that high. And no wonder I've seen Mrs. Jones 5 times in the last year and given her antibiotics." And so. Yeah, it doesn't have to be a formal network, does it? You're not talking about going to a conference and walking around with a sausage roll in your hand and trying to chat to somebody. You're talking about, just when you're, in a bus queue or, anywhere when you're chatting to somebody, that you can spread the word, and then you might, like Dave said, just come across someone it clicks with in that moment.
Absolutely. And I think it's the best opportunity to take that sausage roll amongst Lymphedema Awareness Month aspect to kind of make those connections, because it's a great excuse to have a conversation, to go, actually, I work in lymphedema, or I work in because there's a number of people working in the community that are going to see these swollen legs, let alone having the conversation with them, let alone our practice nurses, let alone everybody else that forms part of that wider team. So as you say, use our own networks. And when we start to speak to other people, they have their own networks, and suddenly the network becomes much, much bigger.
Yeah.
Now, I know we're going to be moving on to our Q&A section. So there is still time for people to post in any Q&As. I've got a couple just to get people started, if that's all right. Now, I'm thinking about your education around where it started and where it is now. What have been the best ways that you found to get over the resistance to, say, education, or the best ways to deliver education? And if there's any differences between, say, delivering to nurses, student nurses, general practitioners, surgeons, because I know you've delivered to a whole host of different audiences.
Yeah, I mean, we deliver to everybody from professors right the way through to, healthcare support workers and volunteers. And essentially we deliver the same program. And it's just the chat around it, and we deliver it face to face. We deliver it on Teams. We deliver it ad hoc. And I think the biggest thing for us is to be flexible. So we work with universities, with medical students, we work with physio students, nursing students. So just being flexible and engaging. And I think, from my perspective, it's the personal nature. It's taking personal stories from the people we're teaching, engaging them into, when you teach people, everybody will know someone who's had cellulitis. Everybody will know someone with lymphedema. Often the lymphedema side comes almost by accident. They suddenly go, "Oh, both legs swollen. That's something, is it?" And then we engage into there. And on top of that, then we turn it the other way, where the patients with bilateral cellulitis, which we see an awful lot of on diagnosis, and we really try and push the fact that's not happening, but educating them to what it is. Because I think it's a much better position to be in when you say to someone, "This is what it is," not just, "It's not that, it's not cellulitis," because that's not that better. We say, actually, it's something else. It's inflammatory legs. I mean, the British Lymphology Society, I mean, we borrow a bit of their work in the inflammatory leg pathway because it's a superb piece of work, and it's a brilliant piece that's part of our training program. And maybe that's part of it. Don't be afraid to acknowledge other people's brilliant work and bring that into your own training to spread the word.
And I think it comes back to that notion, don't reinvent the wheel unless you have to. because other people have done lots of different things. And as you say, it's about that flexibility, but also delivering it in many different mechanisms in different ways. Because I know across Wales, there's an awful lot of times whereby it's engaging in education needs analysis to establish, well, what are the areas that people now want to explore, which then feeds into the programs going forward. Then they might be saying, actually, this is an area I want to know more about, and actually think, well, I actually didn't realize that was so important to you, let alone reinforcing what we're communicating is still having an impact, which is great to hear.
Yeah, I think you're right, Gary, when you say that, and it's similar to what I said earlier. It's that forgetting that what seems like common sense, and then we ask people, did you realize this? And they're like, no. And you're like, oh, I forget that people don't know that. And that's not a criticism of them. I always say, when people talk about, their practice nurse or their GP and, oh, he gave me antibiotics, I'm like, yeah, but remember, he's also treating heart failure and post-op and prostate cancers. And I couldn't do any of that, but all we see all day is cellulitis, and we see a lot of swollen legs. And so we know that bit. That bit we do know. And I don't blame them for not having the plethora of knowledge about what compression garment to put somebody in. That's our bag. And so it's important that they know that we're there to use us and not try to deal with those things themselves when they can use us to deal with those. So yeah, I think, and admitting errors, I think, helps a lot. Being open about, we have some images of cellulitis, and we go through them when we're teaching, and I often say, that one there, I'd have given them antibiotics. I'm a prescriber. I'd have given that person antibiotics, but that in fact wasn't a cellulitis, and I know that now because of this, A, B, and C, whatever it was, so that you're not judging people and not making people feel bad. You're just sharing what is experience.
Exactly. And I think that's actually a lovely point to make, because I know a number of people are really concerned about making those mistakes or appearing foolish, perhaps, in front of other people when we're discussing it. But it's, if people don't talk to us and engage and share those things, we don't know where they're at, let alone how we can help and support to say, actually, the reason I might have made the same thing, but the reason for why I don't do it is because of X, Y, and Z. A bit like, the lower limb inflammatory pathway. Suddenly we're questioning, going, actually, because of the data, it doesn't indicate that it's in bilateral legs. Actually, that's the smallest proportion, if ever, occurs. But if we didn't have the data, we couldn't deliver the education to say why we've changed practice.
Yeah.
So I think there's one thing I'd like to ask was around the data, because I just think actually that has been something that's grown over a period of time. And I do wonder if people think that there's a fantastic button that everybody presses in each of the health boards that sends it automatically to us. I'd love to let people know what the reality is around how the data comes into the service.
So the reality is, for the different bits of it, the reality is that when we started, I had a piece of paper, and Dave was saying, I think we could make this digital. And I was like, Dave, I don't think I'm clever enough to do that. I don't understand Excel. What if I press the wrong button and I delete it all? I'll put it on this bit of paper and I'll give it to somebody else. And so we literally started out with a piece of paper that had things like upper limb, lower limb, how many they'd had, how many antibiotics. It was very basic. Are they diabetic? Are they, thinking about what we might want to capture, male, female. And this was like the first 50. And I can remember Mel saying to us that she wanted us to present like the first 30 odd that we'd seen or something like that. And you're like, oh God, so 10% had diabetes. And we were so naive as to what we were. And now, because it's so huge, and now it's a Microsoft form, thanks to Dave, because Dave champions these, and we can access them wherever we are. And so we're able to, on an iPad or on our desktop, when we finish seeing a patient, enter their details and literally say name, date of birth, address, where they live, their ethnicity, something that we're capturing now that we didn't used to capture, how we're discharging them. Are they being discharged to lymphedema? Did they not have any swelling? So we're not worried about that. Did we give them prophylaxis? Did we give them rescue? Did they have a recurrence? Did they not? All those kind of things. And that's all on a Microsoft form. And so the data that we input is that way. And then we have the other data, Dave, don't we? The data we receive, which is from DHCW.
And that's changed a bit since we started off. Basically, when we first had it, we got everything. We literally, if they had an ICD-10 code relating to cellulitis, we got everything. And we'd end up with, some patients had 30 or 40 diagnosis codes. We've learnt from that. It was really interesting to start with because it helped direct some of it. And that's what I would say. Get a bit more data than you need to start and cut it down. it's much easier going that way than the other way, but do cut it down fast. That's the bit I'm not so great on, is cutting it down quickly. Fortunately, I have Mel in my ear going, no, we don't need that, we don't need that, we don't need that, and very good at going, right, that's the relevant stuff, that's the bit we really need. But we've worked together, and I have to say, this is part, as Lynn says, part of the process. You know, we start off with paper, and I'm quite digital. I like digital. I like the way it feels, so I push that side. But I got some of the other members of the team holding me back, because otherwise I'd go down a rabbit hole that way. But then I bring them on, and that's part of the beauty of our processing. We've had the data in, but don't be afraid of it. But I would say we've now got more data analysis on our team. Oh, they're an absolute godsend.
Ultimately, Dave and I, we're physiotherapists, Dave, aren't we? And we have our biases to things that we might have little skills in that we like, but to have people in place for whom data analysis is their role is so
it's fabulous. And it enables us to do our jobs better. I have to say, back in the day, I was a little bit afraid of data from a clinical perspective. I thought it would affect me clinically. I thought it would tell me what to do from a clinical perspective. And it doesn't. It informs, it helps you. It sort of go, if you're right, you get the evidence. If you're not right, well, you should be changing your practice anyway. But it's a difficult step to go through, I think. And a lot of us are a little bit, we don't want to be told what to do. But honestly, you get the data, it comes in, it tells you, it enables you, you work better, you get better results with patients, which makes us all feel better.
Yeah, I think you'd be amazed what data's out there and what people can access. You might think, oh, I couldn't have that, but that it will be being collected somewhere. You know, it's somewhere in your hospital health board. Someone will be counting how many are coming through the door. Someone will be counting how quickly they go out the door, whatever it is, and it will be being counted. You don't have to know it, but you might know someone who can tell you that, and then it can really help you.
Exactly. And I think those are perfect things to end on. So I'm going to draw us to a close. So thank you, Linda and Dave, for contributing and leading this really interesting webinar and discussion. And thank you to everybody else who's joined us. So today's session has shown us that improving cellulitis outcomes in lymphedema is not just about issuing guidance, it's about building networks, embedding audit and feedback, supporting the workforce development, and strengthening that antimicrobial stewardship. And what has been particularly powerful is seeing how a coordinated national approach can reduce variation, improve confidence across teams, and ultimately support patient outcomes. So for those joining us from outside Wales, I hope today has offered both inspiration and practical ideas that can be adapted within your own regional or national context. And the key takeaway is progress is possible when strategy, data, collaboration, and patient voice come together. And please look for the follow-up information after the session, which will include contact details. And on behalf of Lymphoedema Wales Clinical Network and Sigvaris through their Medical Online Hub series, thank you for your time, your engagement, and the work you continue to do to supporting patients living with lymphedema. And have a wonderful afternoon, and goodbye to everyone.
Goodbye, everyone. Thank you for listening.
Goodbye, everyone.